Good evening, everyone. A warm welcome to our webinar. Without further delay, let's begin. Today, we will be discussing the evolving landscape in the management of HR positive and HER2 negative metastatic breast cancer. We are honored to have Dr. B.K. Smurthy. Ma'am is a senior consultant medical oncologist from Leelabati Hospital, Mumbai, and Dr. Amit Rothan, sir. Sir is a HOD consultant medical oncologist from Manipal Hospital, Bengaluru, as our program directors for this session. So now I invite Dr. B.K. Smurthy, ma'am, to deliver the opening remarks. Over to you, ma'am.
Yeah. So, good evening, everyone. Welcome to this very interesting symposium being held this evening to really go over and review the evolving landscape in the management of hormone receptor positive, HER2 negative metastatic breast cancer. As we know that although we have the endocrine therapy with CDK4/6 inhibitors as the first line, eventually patients would relapse. And we have today very interesting presentations which are going to allude to the therapeutic armamentarium that a medical oncologist now has at their disposal to treat these patients who have metastatic breast cancer progressing on all these therapies. I'm glad to see Professor Pugliano, and it gives me great pleasure in welcoming him. And we are really privileged to have Professor Pugliano, who is an internationally recognized oncologist, very well known in India as well, and with special interest in early drug development and also the breast cancer research. He is also the director of the early drug development and co-chair of the experimental therapeutic program at the European Institute of Oncology. He is also on the steering committee and advisor to the government of Italy. He has many accolades to his name, and which I would begin with saying that shaping the guidelines for breast cancer, being on the panel member of ESMO and ASCO. He is also the president-elect of ESMO at the moment, and he was the co-chair of the steering committee of the just concluded very fruitful and successful St. Gallen's meeting. He has several peer-reviewed articles to his credit, and he has won the accolades as shaping the guidelines, as I mentioned, and several trials as well, clinical trials. So, I mean, if I were to really enumerate all his achievements, I think it would cover the whole 2 hours. So, with all these opening remarks, I think we can just move on to the first presentation, and that is by Dr. Aditya Murali, who is going to be talking on the Destiny Breast 06 primary results and additional analysis. So I invite Dr. Aditya Murali, who is a senior consultant medical oncologist and hemato-oncologist at the Apollo Hospitals, Bangalore.
Thank you so much, Pastor Zanka. Thank you, ma'am, for the kind introduction. And it's indeed a fantastic learning opportunity for us. Mine will be a very short presentation. I'll be talking about Destiny Breast 06. Next slide, please. So DB06 was basically a follow-up trial to the DB04, which kind of proved the efficacy of trastuzumab deruxtecan in the HER2 positive setting. So DB06 considered patients who were hormone positive and HER2 low or HER2 ultra low, but they had to be chemo naive in terms of the metastatic breast cancer setting. So if you look at the percentages, of her HR positive, HER2 negative patient, about 60 to 65% actually qualify as HER2 low, and a further 20 to 25% qualify as HER2 ultra low. Now, HER2 low is basically IHC 1 plus or 2 plus, which in situ hybridization negative, or HER2 ultra low is partial membrane staining in less than 10% of the tumor cells. So the background for this study was to check if we can move trastuzumab deruxtecan to an earlier line of treatment and expand the proportion of patients who may benefit from TDX. Next slide, please. So the inclusion criteria here is quite interesting. I'll spend some time on this. Patients had to be hormone positive metastatic breast cancer, HER2 low or HER2 ultra low. They should be chemo naive in the metastatic setting. That's number one. The second thing is if the patient had received prior lines of therapy, they could have received at least 2 lines of endocrine plus or minus target therapy, or if patient received only 1 line, then the progression should have been less than 6 months of starting first line endocrine plus CDK4, or recurrence within 24 months of starting adjuvant endocrine therapy. So the rationale here was to see is that this is the patient population in whom chemo would have basically been a default option. So to see if trastuzumab deruxtecan is an effective agent in a setting wherein chemo usually would have been the default option. The primary endpoint was progression-free survival, and the key secondary endpoint included overall survival in the HER2 low and in the intention to treat population. Next slide, please. So in terms of the baseline characteristics, I think they were quite well matched. The thing to note here is a third of the patients in the HER2 low subgroup, in the total intention to treat population, and in the HER2 ultra low subgroup, at least 1/3 of the patients had primary endocrine resistance, which is bad disease biology. And an overwhelming majority of the patients across all the subgroups, 85% of the patient actually had visceral disease at baseline. Next slide, please. Uh, Again, in terms of the prior therapies, at least 65% of the patients across all subgroups had received at least 2 endocrine therapies, which means that they would have gone through all the regular gamut of non-chemo based therapies available. Even about 15% of the patients had received 3 or more lines of endocrine therapy. So that is one. In terms of prior CDK4 exposure, a majority of patients actually did have prior CDK exposure as well. Next slide, please. So, talking about the primary efficacy analysis in terms of primary endpoint, which was the PFS, in the HER2 low subset of patients, trastuzumab deruxtecan improved the median PFS by about 5.1 months as compared to the standard of care chemotherapy of physician's choice. In the TDXD arm, the median PFS was 13.2 months with a significant hazard ratio of 0.62. This showed that there was a clinically meaningful improvement compared with standard of care chemotherapy in the HER2 low setting. Next slide, please. Nirav, next slide, please. Yeah. Overall survival is very hard to demonstrate in this kind of a population, primarily because about 20% of the patients in the chemotherapy arm ended up receiving TDXD as a post-treatment discontinuation, and about 17.9% of patients in the chemotherapy arm in the TDXD arm received some. So there was only about 40% maturity, but a statistically significant improvement could not be demonstrated in overall survival. But in terms of the 12-month OS rate, in the HER2 low setting, the 12-month OS with TDXD was about 87.6%, and it was 81.7% in the chemotherapy arm. Next slide, please. This is a more interesting subset, the HER2 ultra low subset. Now, mind you, this is not what our pathologists are used to, and we cannot treat all patients as HER2 ultra low. We need to go back, look at the tissues, or get a fresh tissue and see what qualifies as HER2 ultra low. But in the HER2 ultra low setting, the progression-free survival was very significantly improved with trastuzumab deruxtecan. The median PFS was 13.2 months. The delta, the improvement in progression-free survival was about 4.9 months, and the hazard here was 0.78. This was consistent with the HER2 low population as well. Next slide, please. Anti-tumor activity, when you look at it in terms of the clinical benefit rates, be it the HER2 low or in the HER2 ultra low setting, 75%, three-fourths of the patients actually had some kind of a clinical benefit when they went on trastuzumab deruxtecan, to about 45 to 50% when they went on the chemotherapy arm. Next slide, please. So, whenever we want to use a new drug, at least when you want to use a drug in a new setting, we want to look at the safety summary. in terms of the most common treatment-related adverse event, it was basically in line with the other trastuzumab deruxtecan trials. And in terms of the treatment discontinuation rates, it was about 5.3%. Next slide, please. So, in terms of the severe grade pneumonitis toxicity, TDXT had three patients who actually had grade 5 toxicity, and overall about 5% of the patients had to discontinue TDXT due to pneumonitis. Next slide, please. So the DB06 concluded that trastuzumab deruxtecan was an effective new treatment option for patients with hormone positive, HER2 low and HER2 ultra low metastatic breast cancer following one or more endocrine based therapies in a very tough to treat setting. Next slide, please. Last 1 minute on the update in SABCS. Next slide, please. So some more data was let's go back, Nirav, just 1 second. So some more data was presented in the SABCS 2024. In this, they tried to look at in patients who had less than 6 months, who progressed less than 6 months on first line treatment, how well they did. So even if the patients had progressed within 6 months of first line hormone ED plus CDK4, they did very well with trastuzumab deruxtecan. The median PFS here was about 14 months, and the delta, the improvement was nearly 7.5 months. In the 6 to 12 month and the more than 12 month setting, the efficacy was maintained. Just goes to show that trastuzumab deruxtecan is actually very significant, is quite effective in this particular subset. Next slide, please. So even the delay in the PFS2 was actually clinically meaningful and in favor of trastuzumab deruxtecan in the intention to treat population and in the subgroups. Next slide, please. In terms of disease burden, whatever it was, whether it was a high disease burden or low disease burden, as in less than 3 local or metastatic sites at baseline or 3 or more metastatic sites at baseline, the PFS benefit was observed across these subgroups. Next slide, please. So this update in SCBC has actually concluded that there was a clinically meaningful efficacy benefit versus chemotherapy even when patient progressed on first line endocrine plus CDK4/6 inhibitor in rapid progresses or less than 6 months on first line therapy. And the PFS2 actually favor trastuzumab deruxtecan over chemotherapy in the intention to treat population as well. The safety profile in the subgroups were consistent with the overall safety population. Next slide, please. My takeaway from this particular presentation is that we now have a fairly effective new second line treatment option in hormone positive HER2 negative metastatic breast cancers who qualify in the HER2 low and HER2 ultra low subset. Very significantly, the patients whom we are always quite skeptical in treating in terms of the rapid progressors, even they showed a significant improvement with trastuzumab deruxtecan, especially in the HER2 ultra low setting. Now, this is a challenge to identify these patients, but in this setting, there is a potentially new treatment option. The only word of caution is that we occasionally go back to capecitabine, which was our standard choice in this particular setting. But trastuzumab deruxtecan is not really that much safer compared to an option like capecitabine. Capecitabine is something that we know how to use, and it's not very hard to use. But TDXD may come with its own set of side effects. Thank you so much, and sorry for overshooting time. Thanks, ma'am.
Yeah. So thank you, Dr. Murali, for that very nice presentation. Do we have time for any questions, or can we take it at the end? I think we'll take all the questions at the end. So I would now call upon Dr. Santosh Chellapuram from Hyderabad to speak on the INAVO 120 trial, the primary results.
Thank you, Smruti Madam, for the introduction. So I would be presenting the primary analysis of INAVO 120 clinical trial. So this trial has evaluated below formats. I would simplify the trial in this format of PICO, where the population studies were PIK3CA mutation, advanced hormone positive breast cancer. The important point is those with progressed within 12 months of adjuvant endocrine therapy. So they have taken high-risk patients. What do? They added a novel PI3CK inhibitor, ivanolizumab, and to the background of palbociclib plus fulvestrant. The comparison arm included palbociclib with fulvestrant. What do? The primary outcome they assessed was PFS. The secondary outcome was overall survival, overall response rate, and duration of response. This is in simplified format. What is the study? If we take a study in more detail, in this population, they have tested PIK3CA by circulatory tumor DNA. 92% of the patients were positive for circulatory tumor DNA. If it was negative, they have taken the tissue analysis for the same in this study. The second important point I want to emphasize was there should be no prior therapy for metastatic breast cancer. That is, it's the first line setting of hormone positive they are testing. And because of the prior toxicity of PIK3CA inhibitor, they should have a fasting glucose of less than 126 or HbA1c less than 6, randomized to ivanolizumab plus palbo plus fulvestrant versus palbo and fulvestrant until toxicity or further progression. So if you see the demographics, they have included very high risk hormone positive patients. As you can see, the visceral disease was present in approximately 80%, and the most problematic visceral disease in the form of liver and lung is present only is included in approximately 50% of the patients, and the good prognosis born only was a minority. So it's really a high risk population of advanced metastatic hormone positive breast cancer. And the primary hormone resistance that is very problematic to see is seen in around 1/3 of the population studied in this clinical trial. So when we see here, because the CDK4/6 adjuvant have come later, so only 2% or negligible received prior CDK4/6. Most of them are naive. Prior adjuvant chemotherapy was received in almost 80%. So implication, even in the upfront setting, there were high risk requiring chemotherapy. So the true high risk population that failed are included. When we see the progression-free survival, there is separation of the Kaplan-Meier curves from the start, and there is impressive separation, and there is doubling of progression-free survival from 7.3 months in the palbociclib alone versus ivanolizumab if we add, it is 15 months, which is statistically significant with a impressive hazard ratio of 0.43. Very wide separation from the start implies that it is very effective from the start, even controlling those who progress very early. When coming to overall survival in the interim analysis, it is immature and the hazard ratio wasn't crossed. We have to wait for the maturity of the overall survival. Next, coming to what is the overall response rate. Sometimes the burden of disease is more and we expect very rapid response to have. It shows an overall response rate of approximately 60%. When we include even the stable response, it increases to 75%. Almost 3/4 of patients will have minimum of disease stabilization, and the delta difference is almost impressive, 33% between the two arms. When we see the duration of response, it is significantly higher in the experimental arm with 18.4 months versus 9.6 months in the control or the standard of care arm. The most important is once it has significant improvement, what are the toxicities like? It has more of mucosal inflammation and stomatitis, hyperglycemia, and diarrhea. I want to draw your attention to the grade 3 and 4, which are minimal compared to the all grades. So majority of the grades of stomatitis or hyperglycemia or diarrhea are grade 1 and grade 2. Important thing is in the clinical trial, they did not use dexamethasone mouthwash for controlling the stomatitis. With the available in clinical data of using dexamethasone mouthwash, we can still control the stomatitis and mucosal inflammation. So when we see to the treatment discontinuation rates, it is 6% in the experimental arm compared to 0.6% in the control arm. So what did the authors conclude is it significantly increases the PFS. Trend to OS improvement is there, but we have to wait they have different limitations for the p-value and hazard ratio. So it has to cross. Let's wait for it. So it is an effective combination that affects. What are my conclusions? In this trial, definitely very high risk patients are included. And cell-free DNA is a feasible technology which identifies 93% of patients with PIK3CA. It is a founder mutation. Whether we do at the baseline or advanced, it will help. It raises the question, should we do upfront testing of PI3CK testing in a case of advanced hormone positive? Now we do after first line setting. And the important thing that happened, this sometimes happens with clinical trials, is evaluation of control arm over time. So with time, we have seen that palbociclib failed to show the OS advantage, but ribo and abema showed the advantage. What would have been if these were the partners, where the toxicity is more, we have to see. It should be offered for all comers or those patients who have primary progressors. We being diabetic capital of the world, how do we manage this? We have to manage the control way. What happens if I use this agent sequentially? The OS benefit will really answer this question. With this, I thank the organizing team and AstraZeneca and Smriti Madam for providing me the opportunity. Thank you very much.
Um, Thank you, Doctor. And that was a nice presentation. I have one question here, and we have Professor Pugliano, so I think it's very important. Now, this has been projected as a first-line therapy in patients who relapse in hormone receptor positive or HER2 negative. Now, if we have these two presentations. Where would you put a patient who has HER2 low, but also has a PIK3CA mutation? How would you sequence these therapies?
No, personally, I would give first line inavolisib plus palbo plus endocrine therapy, because in any case is a patient with metastatic breast cancer, HR positive, and still, in my opinion, the first line therapy should be an endocrine therapy. We know also from a press release that this combination will give an overall survival benefit. So we will see this data at ASCO, but I would not anticipate the use of ADC here.
Okay, and the second question is, do you see in the future palbociclib being replaced by either ribo or abema, since in the metastatic setting they have shown the overall survival benefit as opposed to palbo?
Oh, yes, of course. What we are going to do now, we are using more ribo and abema in combination with endocrine therapy. But when you have a triplet combination, we have to be honest, palbo is the better tolerated. So that's why all the studies combined palbo with other biological agents. So at the end of the story, palbo is better to be combined with other targeted agents with respect to ribo and abema.
Okay. Thank you, Professor. If there are no more questions, any questions from any of the other speakers or the audience? I don't see any questions in the chat box. So I think we can move on to the next presenter. And that is Dr. Anbarasan Sakar from Mumbai. He's going to be presenting the data of Capitello 291, the primary results and the PFS2. Over to you, Dr. Sekar.
Good evening. Good evening, organizer. Thank you for giving me this opportunity. Today we are going to discuss about Capitello 291 study design. In the year of 2023, there were 3 oncology drugs in metastatic hormone positive setting approved, and one among them is capivasertib plus fulvestrant combination in AKT pathway alteration mutations. Going on to the study design, it is a phase 3 randomized double-blinded placebo-controlled study design. This study is designed based on the previous study, phase 2 study, where capivasertib is shown some efficacy in patients who are having AKT PIK3CA alteration pathway mutations. Inclusion criteria for the study design is patients who are having metastatic advanced breast cancer setting, and they have taken at least 1 or 2 lines of prior endocrine therapy has been included into the study design. Unlike other different types of SERD therapies, here even patients who are taken chemotherapy in the 1 line of chemotherapy in advanced metastatic breast cancer setting also been included into the study design. and prior CDK4 inhibitors patients has been allowed. At least 50% is required for the study design to be enrolled. And other features, they are like in other similar studies, like they should have adequate glycemic control. If the patient is a known diabetic, they should not be on insulin. These were the inclusion criteria for the enrollment into the study design. They have been randomized into two arms. One is capivasertib plus fulvestrant arm, and second arm is placebo with fulvestrant arm. The interesting thing about the study is capivasertib dosage duration. Here it is given at us 400 mg twice a day, 4 days on and 3 days off duration. Why this sort of dosing effect? This dosing effect is more suitable for the patient because to overcome the decrease in the side effect profile for the patients. Coming to the primary endpoint, it is a dual primary endpoint. Basically, they look into progression-free survival in two subset of population. One is in the overall population, and second one is the main target population, that is AKT pathway alterated population. That is either mutation in the PIK3CA or AKT or loss of PTEN in the population. And the secondary endpoints include overall survival, AKT alteration, and the objective response rate include for the overall population as well as AKT pathway alterated population. Some of the key important baseline characteristic features with respect to CAPItello 291 study design is almost 70% of patients were pre-treated with CDK4/6 inhibitors. This is the current scenario in our routine practice also. Most of the time, when majority of our patient receives first-line endocrine therapy along with either CDK4/6 inhibitor in the population. And they include highly aggressive disease. Almost 50% of patients had visceral metastasis in this population. Next slide. Coming to the primary endpoint, with respect to the primary endpoint overall population, it has met its primary endpoint where the median PFS is 7.2 versus 3.6 with an hazard ratio of 0.6. One thing I would like to highlight over here is the presence of, when you see the earlier duration up to level of 2 months, the curve is merging together, and after that it is showing separation. So like this sort of PFS curve we seen with LSS drug also, but there is earlier there will be lot of event will happening, but over a period of time the curve tends to separate and separate for a long period of time. This is seen with use of capivasertib fulvestrant combination also. Next slide. This is with respect to AKT pathway alterated population. Here also the median PFS is achieved, where the placebo with fulvestrant arm it is 3.1 months, whereas with capivasertib plus fulvestrant arm it is 7.3 months, and with a better hazard ratio of 0.50. Here also I would like to highlight that even though there is merging of two curves are there, but the separation starts a bit early when the patient is having AKT pathway alterated population. And one thing I would like to highlight is here they included heterogeneous group of population, and the percentage of patients who are having AKT pathway related mutation is close to 40%. Among them, PIK3CA alteration is seen close to 30% of population, and the rest of well will be between AKT and PTEN population. And these 1 to 2% of patients had combination of PIK3, AKT as well as PTEN mutation also in this population. Next slide. And this is with respect to different sort of mutation, how the drug performs with respect to different sort of mutation. With respect to PIK3CA, AKT, and PTEN, there is no doubt that capivasertib fulvestrant showing very good response rate, where the median PFS is 5.6 versus 2.1, and in patients who are having AKT alteration, it is 9.1 versus 3.7, and with respect to PTEN mutation, it is 9.1 versus 3.6. There is good amount of separation is there, and the hazard ratio is also 0.5. Next slide. And it has also shown progression-free survival too. The extended PFS benefit also seen with combination of capivasertib with fulvestrant in both overall survival as well as PIK3CA AKT alterated population. Next slide. So we have seen the drug is showing efficacy in terms of progression-free survival. Next, we are going on to see how much side effect profile, whether the drug is safer to use in overall population or not. With respect to side effect profile, the side effect profile with respect to serious adverse event is 16% compared to the placebo arm, it is 8%. I would like to highlight other couple of features. When it comes to drug discontinuation, almost 13% were discontinuation rate with respect to capivasertib and fulvestrant. With respect to placebo arm, it is only 2%. And majority of the discontinuation is mainly because of capivasertib. And the common reason for discontinuation of capivasertib is skin rashes. And other thing is dose interruption is required in close to 35% of population, with dose reduction is seen in only 20% of population. Next slide. Compared to the historical cohort like PIK3CA, alpelisib, or everolimus, this drug seems to be little safer also. With respect to the side effect profile, as expected with other mutants like PIK3CA, AKT, or PTEN inhibitors, which were being used previously, like mTOR inhibitor also, that incidence of diarrhea, skin rashes are common, but the incidence of grade 3 side effect is comparatively lesser. Among them, the most common side effect is diarrhea. Even the grade 3 side effect is close to 10%. With respect to rash, it is less. It is around 5% with respect to grade 3 rash, and grade 1 to grade 3 it is close to 23%. And the incidence of hyperglycemia is much lesser because of the selective inclusion of the population. Also, the incidence is much lesser. The grade 3 event is less than 5%. One thing I would like to highlight here is incidence of stomatitis is close to 15%, but the grade 3 event is not higher. It is less than 2%. When the principal investigator presented this data, one thing they highlighted is with respect to management of side effect profile is they use prophylactic antihistaminics, non-sedating antihistaminics to the patient while starting the drug also. This helped in reducing the side effect profile for the patient also. Based on the appearance of skin rash, they used to titrate the level of side effect. Other thing is whether this drug is safer for all sort of population, even in patients who are elderly more than 75 years. The author replied that even in 75 years, there is no need for dose reduction because these drugs seem to be safer. One thing which helped out in such population is dosing interval. As I highlighted in the earlier also, 4 days on, 3 days off is highly helpful for such patients to recover from the side effects while taking this drug. Next slide. And with this, we will come to the conclusion. The capivasertib plus fulvestrant provides statistically significant and clinically meaningful improvement in PFS in both overall as well as AKT pathway altered population. And the benefit from capivasertib was consistent across clinically relevant subgroups. And the intent is mainly want to treat the AKT pathway altered population. But tissue diagnostic testing takes much longer time. That is also one reason they try to include overall cohort into the study design. And they've seen the response is much seen better with patients who are previously treated with CDK4/6 inhibitor, whereas when we seen with elacestrant, there is a significant difference gap was there, like whether patient is having duration of CDK4/6 inhibitor usage is less than 6 months or 1 year. Such difference are not reported in the study design. And other thing is they have shown good response with respect to patients who are having visceral metastasis, also like liver metastasis. Overall survival follow-up is ongoing, and this drug capivasertib plus fulvestrant is approved by FDA in 2023 for patients who are having PIK3CA AKT pathway altered population. Thank you. Thank you for giving me this opportunity. Thank you.
Thank you, Dr. Sarkar, for that nice presentation. Any questions from any of the other participants or from, I don't see any questions in the chat box. I think I'll take the liberty to ask one question, and that is, in the study, it showed that there was a benefit in terms of PFS also in the overall population, but the drug is approved only for the the gene altered or mutated patients. So what is the reason for this? So if Professor Cugliano could tell us this, and
so can you repeat the question? Which is the question?
The question is that the study showed that there was a significant PFS benefit not only in the gene altered population, but also in the overall population. And but looking at the forest plot, actually the drug is approved only for the marker expressing population. So any comments on this?
I believe in the second line, we need to approach patients with a biomarker-driven approach. So I saw that there was a benefit both in intent to treat and in the PI3 kinase AKT PTEN mutant population. But if you go in the details of the data, in the post-CDK4/6 inhibitors, in the overall population, you have 5 months of median PFS finally. Okay, that you can improve eventually in the PI3 kinase AKT and PTEN altered population. So personally, I believe we should select patients according to specific biomarkers.
And the second question is, if we are going to use the Innova 120 in the first line, then where do we stand with this drug?
Oh, this is an excellent question, because some patients in the Capitello trial are in the same setting of the Inavo trial. But looking at the data, overall, I believe a combination of Inavo-Palbo and fulvestrant is better. So both in terms of median PFS, and now we have data of overall survival that I don't know if we will never see for capivasertib.
Okay, thank you. So we quickly move on to the next presentation, and that is the AMBER-3 primary results. And we have Dr. Rishabh Kothari, medical oncologist from Ahmedabad, who's going to do the presentation. Over to you, Dr. Rishabh Kothari.
Yeah. Thank you, ma'am. Thank you, Astra. So I would be presenting AMBER-3. Next slide, please. So here in hormone positive metastatic breast cancer post CDK4/6 plus endocrine therapy progression, combination of oral SERD and abemaciclib was given. So the background is that beyond CDK4/6 inhibitor on progression, now we have couple of datas where continuation of CDK4/6 inhibitor or switch to other CDK4/6 inhibitor helps the patient post Monarch and this AMBER-3 trial. Fulvestrant, which is a injectable SERD, is generally used on progression to AI plus CDK4/6 inhibitor, but a lot of patients do have issues because of pain and induration after fulvestrant. Imlunestrant, which is an oral SERD with CNS activity, has shown activity in this setting. Even abemaciclib has shown activity post progression to CDK4/6 inhibitor. And based on this, current study evaluated oral SERD with or without abemaciclib versus standard of care endocrine therapy in patients with advanced breast cancer. Next slide, please. So here, patients with ER positive, HER2 negative, advanced or metastatic breast cancer patients who have progressed on aromatase inhibitor with CDK4/6 inhibitor in adjuvant or first line setting with no other treatment in advanced breast cancer were taken, performance status of 0 to 1. They were randomized based on prior CDK4/6 inhibitor treatment, visceral mets, and geographic region into imlunestrant alone or with abemaciclib or standard of care endocrine therapy, which was either exemestane or fulvestrant. Co-primary endpoint was PFS in intention to treat population. AM first versus third and AM second versus first were compared in patients with ESR1 mutation and in intention to treat population. Next slide, please. So this is PFS for imlunestrant alone versus standard of care endocrine therapy, which was a primary endpoint. In ESR1 mutated patient, the median PFS was 5.5 months versus 3.8 months, hazard ratio of 0.62, not crossing unity, and a p-value of less than 0.001. And the separation is quite evident. In intention to treat population, median PFS is 5.56 versus 5.5 months. Hazard ratio is 0.87, crossing the unity, and p-value is less than 0.12. The separation of curve is not much in intention to treat population. Next slide, please. So in imlunestrant plus with abemaciclib versus imlunestrant alone, the PFS was 9.4 months versus 5.5 months with hazard ratio of 0.57, confidence interval not crossing unity, and a p-value of less than 0.001. Next slide, please. So in important subgroups, the combination when compared to oral SERD alone, in ESR1 mutated patient, it is 11.1 month versus 5.5 month, hazard ratio of 0.53. In patients without ESR1 mutation, again, it is 9.1 month versus 5.5 months, hazard ratio of 0.59. In patients with prior CDK4/6 inhibitor, median PFS is 9.1 versus 3.7 months with hazard ratio of 0.51. And patients with PI3K pathway mutation, median PFS is 7.6 versus 3.8 months, hazard ratio 0.61. So in all important subgroups, we can see that the combination is working when compared to oral SERDs alone. Next slide, please. So oral SERD alone has shown PFS benefit, especially in ESR1 mutated patients. However, it was not significantly different when we see intention to treat population. Uh, though overall survival data is immature, safety profile is favorable, and largely oral SERD specific concerns like cardiac and ocular were not there. When this was combined, oral SERD was combined with abemaciclib, it significantly improved PFS in uh, most of the subgroup compared with oral SERD alone, irrespective of ESR1 mutation, irrespective of prior CDK4/6 usage, and irrespective of PI3K mutated pathway. So probably combination is a way forward, and it is potentially all oral targeted treatment option for patients who have progressed on first line endocrine therapy plus minus CDK4/6 inhibitor. Next slide, please. I think now with two studies post CDK4/6 plus AI progression, there is role of abemaciclib plus SERD, and oral SERD would be preferred generally. And genomic testing would be very important once patient has progressed on first line CDK4/6 inhibitor plus endocrine therapy. And the combination did well not only in ESR1 mutated patients but in most of the subgroups. So I think the combination would be a better choice when we select our patients. If we don't have anything, the classical genomic, if PI3K pathway is there or BRCA is there, we have other options also. But if it is not there, probably this would be a treatment of choice. Thank you.
So, thank you so much. I would just like to ask one question here. Is there, because this drug also has CNS penetration, and then you have abemaciclib also with CNS penetration. So is there any data about any effect on the CNS involvement?
No, actually, we don't have so many data on imlunestrant in brain mets. There are some studies ongoing. There were also studies of abema. You know, there is actually a trial ongoing with the elacestrant in patients with HR-positive brain mets. But you can understand that in this patient population, it's quite uncommon not to have brain mets. It's quite rare in HR-positive disease to have brain mets. Maybe we need for the future some studies of combination in the triple positive population. In those patients, HER2 positive, HR positive.
So in your practice, where do you put this drug? I mean, you look at the ESR1 mutation. So do you use elacestrant, or do you go for this, or do you use the combination?
Until now, it's still not approved, imlunestrant. The only oral SERD approved is elacestrant, an ESR1 mutant. Once approved, I believe I would use imlunestrant only in ESR1 mutant as a monotherapy. For the combination here, you know, the control arm was not a standard of care. So here we compare A versus C, but A was not the standard of care. So for sure the data are interesting, but we have some limitations here. First, many of the patients did not receive all CDK4/6 inhibitors. So we have some patients who received, some others who did not. So this, for me, is a limitation of this study.
Thank you for those comments. And then we move on to the last presentation, and that is by Dr. Rana Joseph, and he's going to be presenting the data of post-MONARCH trial results. So she's a medical oncologist from Trivandrum Regional Cancer Center. Over to you, Dr. Rana Joseph.
Thank you, madam, and thank you, the organizers. So finally, we'll be discussing on the results of the post-MONARCH trial, which is abemaciclib plus fulvestrant versus fulvestrant plus placebo in hormone receptor positive metastatic breast cancer post-CDK progression. Next slide, please. So as you all know, standard first-line treatment in hormone-positive MBC is CDK plus endocrine treatment. Abemaciclib is a potent oral CDK inhibitor. It was approved both in the adjuvant setting and also in the metastatic setting. both as a single agent or in combination with AI and fulvestrant. So regarding the background, the post-CDK progression, the phase 2 trials were showing conflicting results. The Palmyra and PACE trials were negative, whereas Maintain showed a PFS benefit. So this is a phase 3 study which reports the efficacy and safety of continuing CDK inhibitor post-CDK progression. Next slide. So coming to the study design, so adults with hormone positive, HER2 negative metastatic breast cancer post-CDK progression were randomized into two groups, abemaciclib plus fulvestrant versus placebo plus fulvestrant. The stratification was based on geographical region, visceral mets, prior CDK duration. The primary endpoint was PFS and the rest were the secondary endpoints. Next slide. Coming to the baseline characteristics, both the control trial arm and the control arm were comparable with respect to their baseline characteristic. The median age was around 60 years, predominantly Western population, and visceral metastasis was present in around 60% of patients. Next slide. Regarding the prior treatment history, the palbociclib were the most frequently used CDK inhibitor, around 60%. Ribociclib was around 30%, and less than 10% of patients received abemaciclib in the first-line setting. And most of the patients, the treatment duration of prior CDK therapy was more than 12 months. Next slide. Coming to the results, the investigator-assessed PFS was the primary objective. At 6 months, it was showing 50% versus 37% in the investigator-assessed PFS. In the blinded independent review, it was 45% versus 68%. So the investigator-assessed PFS was showing a 27% even PFS-related even risk reduction with abemaciclib plus fulvestrant. And this benefit was consistent across the subgroups, including all the stratification criteria. Next slide. This is the PFS in key subgroups, and although not statistically significant, the PFS benefit was observed in most of the subgroups. The exploratory analysis was also demonstrated the PFS benefit in patients with ESR1 mutated patients and also in PIK3CA mutated patients. Next slide. Overall response rate was 17% versus 7 by the investigator assessment, and 23 versus 8 in the blinded independent review. Next slide. Coming to the safety analysis, we all know about abemaciclib. So similar to the previous studies, GI symptoms were most common, including diarrhea, nausea, vomiting, and abdominal pain, followed by cytopenias. And the control arm, the placebo plus fulvestrant arm, where all these symptoms were relatively less. There was one treatment-related death occurred in abemaciclib plus fulvestrant, that is because of the pneumonia. The dose reductions were 30% versus 3%, and 6% of patients, the drug is discontinued, treatment is discontinued because of the toxicity. Next slide. Coming to the investigator's conclusion, this is a phase 3 trial, abemaciclib plus fulvestrant after progression on post-CDK on CDK inhibitors plus endocrine treatment significantly improved PFS compared to the control arm. There was a 27% reduction in the PFS event risk, and the PFS benefit was observed consistent with the pre-specified subgroups. So the safety profile is consistent with the non-abemaciclib profile. So the investigators concluded that this is a treatment option for patients with advanced breast cancer, regardless the biomarker status. Coming to the last slide, that is the next slide, please. So this is the first phase 3 trial, which showed the benefit of continuation of CDK inhibitors in post-CDK progression setting. And we all know the post-CDK progression, the treatment is based on the biomarker-driven treatment. So this is an option in which in those patients without a biomarker positivity. So because this was showing there was no safety new safety signals were observed in this trial. So in that particular subgroup of patients, we can consider this as an option. Thank you.
Thank you, Dr. Joseph. We have two questions in the chat box, so I think I'll address those before we move on to Professor Pugliano's talk. So the first question is from Santosh Kumar, that Elcestrant versus Imlunestrant. What is your view on these two SERDs, oral SERDs? Professor Pugliano?
Personally, the best way to identify ESR1 mutation, in my opinion, is the liquid biopsy, because mutation of ESR1 are subclonal. So it's more easy to find them in the liquid biopsy rather than in the tissue biopsy. So that's why in both trials, the preferred test was exactly the liquid biopsy.
The second question is, how do you select between the SERD plus CDK4/6 inhibitor or the AKT inhibitor versus TDXT if patient has a HER2 low after progression on CDK4/6 inhibitor?
But the study DESTINY-6 was designed after 1 or 2 lines of endocrine therapy. So I prefer to do a second line of endocrine therapy in the majority of the patients, since patients rapidly progressive to CDK are less than 10%. So in the real world setting, a first line CDK4/6 inhibitors, then biomarker driven approach for the second line. And then after this, we move to the ADC.
Thank you, Professor Pugliano. So with that, we conclude the first part of the session. And now I invite Professor Pugliano to present his the talk on recent advances and treatment sequencing in HR positive, HER2 negative metastatic breast cancer post CDK4/6 inhibitors. And I think he will put into proper perspective how we would use the various options which we have discussed so far and which have received approval.
Yes, thank you. I believe the majority of the speakers already presented in detail some data that I am going to repeat and eventually to comment, of course. So let's start from the treatment algorithm. So in the first line setting, we have as a primary line of treatment CDK4/6 inhibitors plus endocrine therapy. Once INAVO will be approved in the PI3 kinase mutant endocrine resistant population, you may add to CDK4/6 inhibitors also a PIK3CA inhibitor. But in the second line, you will see over here, the standard of care is a biomarker-driven approach. So if PI3 kinase mutant or AKT or PTEN mutant, you can propose fulvestrant and capivasertib. If a PI3 kinase mutant alone, you have also the option to use alpelisib. If ESR1 mutant, you can use elacestrant. If germline mutant, you can use a PARP inhibitor. For all the other patients in which you cannot use targeted agents, or you switch endocrine therapy plus a CDK4/6 inhibitor, or you use everolimus and exemestane. Following progression to the second line, here, you can see over here, you can really consider two different approaches. One, to give first a chemotherapy. Second, to move directly to trastuzumab deruxtecan. You know perfectly that the studies of first line, the majority of them have been designed for endocrine sensitive disease, Monarch 3, Paloma 2, and Mona Lisa 2, and for endocrine resistant disease, Monarch 2, Paloma 3, and Mona Lisa 3 and 7. Overall, all the CDK4/6 inhibitors reached the primary endpoint, that was median PFS, but when moving to overall survival in endocrine sensitive disease, you will see you have an improvement in OS from Ribo and from Abema, but you don't have from Palbo, where the overall survival in Paloma 2 was not reached. And overall, CDK4/6 inhibitors are very similar for the endpoint of median PFS and not for the endpoint of overall survival, in which again, Palbo is inferior a little bit to ribociclib and abemaciclib. So the main point is what to do when you progress to CDK4/6 inhibitors. And you know that mechanism of resistance can be a primary resistance or a secondary resistance. And overall, you have an upregulation of several pathways that can be considered. Many of them can be considered a target for treatment. First, some studies on CDK4/6 inhibitor beyond progression have been done in the past. If you remember, there was a study of Abema after PD on Palbo, another one that was the Pioper, and finally the PACE using also abemaciclib. The first trial to confirm that there was a potential to explore a CDK4/6 inhibitor beyond progression was the MAINTAIN trial, a phase 2 randomized trial in patients who progressed to first-line endocrine therapy and randomizing to ribo plus switch of endocrine therapy, placebo and switch of endocrine therapy. Marginal benefit in terms of median progression-free survival. The second study was the PostMonarch. Our colleague already very well presented the data. Here, there is again a marginal improvement in median progression-free survival. Of course, if you consider that many patients following CDK4/6 inhibitor are ESR1 mutant, of course, here there is a potential to explore other type of approach. But here I would like to mention the PADA-1. This study will be very actual in a few months from now, since the data of the SERENA-6 are going to be presented. In the PADA-1, patients on AI Palbo received the serial testing with liquid biopsy for ESR1 mutation. And once ESR1 mutation was detected without a radiological progression, patients have been randomized to fulvestrant plus Palbo versus the same treatment. If you remember, the trial was positive. There was an improvement of median PFS from 5 months to 11 months. And the SERENA-6 is exactly the same design. And you test for ESR1 without radiological progression. And once ESR1 detected by central testing and no evidence of disease progression, there is a switch to camizestrant. We know from a press release that the trial is positive. The question will be what we are going to do, who will pay for the serial testing, but this is a mindset-changing trial. Now, of course, we know already the data of oral SERD post-CDK4/6 inhibitors. The only trial that included all patients in the post-CDK4/6 inhibitor setting was the EMERALD trial, in which the co-primary endpoint was PFS in all patients and PFS in ESR1 mutant. The trial was positive, much more in ESR1 mutant, and if you remember, duration of previous exposure to CDK4/6 inhibitor translate in more benefit from elacestrant in the post-CDK4/6 inhibitor, with a median PFS for those patients who received 12 or 18 months of previous CDK4/6 inhibitors, close to 8 months. Naturally, we will see also the data of camizestrant in this setting, in which the data seems to be very promising, close to 7 months in the phase 2 randomized. And then we have the old everolimus. We know that the Bolero-2 was not designed after CDK4/6 inhibitors, but is a generic drug, still available, may work, with the marginal benefit in median PFS. And finally, the alpelisib trial that was the SOLAR-1, in which in patients who never received CDK4/6 inhibitors, median progression-free survival was close to 11 months. 11 months similarly to the inavolisib arm. That's why the BYLieve trial was designed in the post-CDK4/6 inhibitor. The median PFS of alpelisib is close to 7.3. Finally, what to do in the first line? In the first line, you know perfectly that someone should close the microphone. In the first line, we saw the data of the INAVO trial. Of course, this will be practice changing because we know that beyond the median PFS benefit, there is also a trend for overall survival, and the final data on overall survival that are positive will be presented. And at the end of the story, capivasertib. We discussed already the data, improvement in median PFS in the intent to treat population. In the subgroup analysis of patients in the post-CDK4/6 inhibitors, we have a marginal benefit. Don't forget that another option are the PARP inhibitors. We have olaparib and talazoparib. Both can be used in germinal BRCA mutant with HR-positive disease. And finally, the EMBER-3 study that was extensively discussed, in which you have, of course, a marginal benefit in ESR1 mutant, very similar to the EMERALD. No difference when you compare imlunestrant to standard of care that was fulvestrant in the patient population intent to treat. And of course, a benefit when you compare imlunestrant plus CDK4/6 inhibitors versus imlunestrant alone. So can we consider the novel ADC also after progression to CDK4/6 inhibitor before starting a chemotherapy? We know that several ADC are actually used. The data of DESTINY-4 positioned trastuzumab deruxtecan after 1 or 2 lines of previous chemotherapy. The trial was extremely positive for overall survival, so this is for sure practice changing. And in the updated analysis of median PFS, there was a confirmation of the PFS benefit. Don't forget that in all the subgroup, TDX was better than a standard chemotherapy in the setting of DESTINY-4. And still, a complaint can be the toxicity because we have nausea, we have transaminitis, but we know how to use very well this drug now, also to avoid to have a fatal evolution of ILD. That's why the DESTINY-6 was designed. The idea was to move TDX before and to test the activity in HER2 ultra-low. We designed the trial considering also that all patients in the standard of care did a crossover to trastuzumab deruxtecan. So here we will never see the data of overall survival, but if TDX give overall survival benefit after chemo, for sure will give overall survival benefit before chemo. In the DESTINY-6, median PFS was improved from 8 months to 13 months, and there was a trend in the landmark analysis for overall survival. Activity was also observed in HER2 ultra-low with an improvement from 8 months to 13 months, with again a hazard ratio of 0.63. The most important thing, of course, is that any subgroup derived the benefit, and consider this. We know that 86% of patients in the DESTINY-6 had visceral mets, and the overall response rate was 57%. If you give a chemotherapy, response rate is 30%. So you have an improvement in terms of PFS, but you have also a better response. Safety was very similar, and TDX, in my opinion, should be considered when you progress to a first or second line endocrine therapy. And the first line can be or TDX or chemotherapy, maybe for patients with a low tumor burden. Sacituzumab is another drug approved in this setting. We have the data from triple-negative disease, but we have the TROPiCS-02. And in later lines, sacituzumab can improve both median PFS and overall survival. The most important thing also is management of toxicity. We know that we have some pharmacogenomic studies using UGT1A1 status specific polymorphism to predict toxicity. Finally, we have TROPION-Breast01. This was developed in the similar setting of DESTINY-4. Dr. Aditya Bardia presented it at ESMO. Data was compared to standard of care. There is an improvement in median PFS from 5 months to 8 months, but there is no benefit on overall survival. But we know that also here, in the standard arm, many patients received TDX. That's why there is no overall survival benefit. Safety profile is a little bit different. Mucositis, ocular events, and no ILD. New trials are ongoing now with the ADC. I would like to mention the ASCENT-7, SACHI versus standard of care in a similar setting of DESTINY-6, and then the PROFUSE using sacituzumab tirumotecan, the new anti-TROP2. Main question, can we sequence ADC? We know that when we sequence SG to TDX, we have a median PFS benefit from SG and a shorter benefit from TDX, and the same thing if we sequence TDX to SG. So the second ADC has a less performance, maybe for toxicity or to cross resistance, of course. So what to do today in HR positive, HER2 negative? The first line setting is still, in my opinion, CDK4/6 inhibitors plus endocrine therapy. In the second line setting, we have a biomarker-driven approach. And then in HER2 0, real 0, you can give first chemotherapy and then sacituzumab govitecan. If you have an HER2 low and HER2 ultra low, in case of bone-only indolent disease, you may consider capecitabine first. But if you have a visceral dominant disease and rapid progression, in my opinion, TDX is the best option. So thank you very much indeed, and I will be very happy to take questions.
Thank you, Professor Cugliano, for that excellent talk. We have some questions from the audience. One of them asks, you already addressed the issue that you prefer a liquid biopsy to detect the biomarkers. Now, this concept of doing both tissue and liquid biopsy concurrently, what is your opinion about this strategy in metastatic breast cancer?
Now, some mutations can be detected better with liquid biopsy, namely ESR1, but to detect PTEN alteration or AKT, Dr. Samer is right, we need to do a tissue biopsy. Of course, we have to be fast because a patient in the second line following CDK4/6 inhibitors does not have a long PFS. If you saw in all the studies, 7 months. So the results should be expected in 3 weeks, not later. But personally, if you would like to test for ESR1, I would use liquid only. For the other alteration, I would complement with tissue.
Okay. There's one question. One is that one of the patients of Dr. Neha is on palbociclib and letrozole for 9 years and with only bone-only meds, and is still in CR and to be continued. If she develops a recurrence, what should be the next line of treatment?
Dr. Nia is an excellent patient. These are very rare. So if she progresses, of course, I would do the test for ESR1. My first option in this patient will be elacestrant because, with 9 years of control of disease, it's a huge result. If you don't have access to elacestrant, you can give fulvestrant to this patient, or you can give fulvestrant and everolimus. But these are the patients highly endocrine sensitive in which it's better to move with a second-line endocrine therapy because, in my opinion, there is still space. If no alteration, you can give also, again, fulvestrant and palbo like in the PADA-1, since you stopped in this case palbo and then you are maintaining with letrozole. So here we have several options.
Well, thank you, Professor Cugliano. And there's one more question about what is the role of PARP inhibitors in BRCA-VUS. And here I'd just like to add one more point to this question, that sometimes when there's a BRCA-VUS, it's suggested by the genetic counselors that you should test the family. And if all the family members, the next generation, also have this mutation, then how significant is it? And then how are you going to deal with this patient?
Of course, answering to the question, the data on PARP inhibitors are only on germinal mutation pathogenetics. So with the VAS, we cannot give olaparib or tarazoparib. If you remember, last year at ASCO has been presented a very nice study in patients with breast cancer with somatic mutation of BRCA, with some activity, and also in germinal PRALB2 there is activity. And I agree with you, if you have a VAS in a patient, I would test all the family, because also if the other components of the family have the same VAS, this patient should be followed up, of course, because a VAS, you know, may become a pathogenetic variant if many patients may harbor exactly the same mutation.
Um, uh, any more questions from any of the other panelists or Dr. Amit Rautan, who is there, my co-chair? Well, I have a question for you that, looking at the post-MONARCH study, there was a lot of informative censoring of the data. And that is why otherwise, if you look at the raw data, it's just 0.7 months, here it's 0.7 months difference. But if you look at the BICR data, then it's quite a significant difference. From 27%, it jumps to almost more than 40%. So what's your take on this informative censoring? Because that always tends to sort of benefit the experimental arm.
I agree with you. I believe we should look in the data in details because what is presented usually it's a separation of the curve with an enthusiastic reaction from the audience. But I agree with you. I don't believe in the post-CDK4/6 inhibitor in my clinical setting. ABEMA can perform by 7 months. The majority of patients at the first reevaluation will progress unless you have a patient like the patient we presented before for 9 years on CDK4/6 inhibitors. The initiative of Common Sense, that was launched by Vishal Gali and Vinay Prasad. I believe when we present the data, we should declare at least the censoring and to be more honest on the way we present specific data. You are right.
I'd like to ask a question, Professor.
Yes.
When we have patients treated with CDK4/6 and hormone AIs first line, and they do well for probably 2 years or so, and then you did a testing, and you found both an ESR1 and a PIK3 mutation. And
Yes.
once you get all the drugs approved, would you favor a Capitello-like approach, or would you follow an EMBER-3-like approach? What do you think is the dominant pathway in this kind of when you have double mutants?
This is an excellent question, and Dr. Aditya Bardia performed a subgroup analysis in those patients with concurrent mutation of ESR1 and PI3 kinase. And the performance of elacestrant is not so excellent. So when I have both the mutation, I prefer to use a combination therapy. So I would go to capivasertib and fulvestrant, because having a dual mutation, it means there is also a mechanism of secondary resistance, and personally, I prefer a combination therapy rather than a single therapy.
Okay, thank you. And one more thought was, why is it that PIK3 mutation in the first line setting, so if we skip the INAVO data, we leave that. If you look at the CDK4/6 AI data, like the MONARCH 2, if you look at, you have better benefit.
Similar PFS.
Better PFS in the PIK3 mutants versus the wild types.
You are right. You are right, because if you look at the data in endocrine resistant disease, the median PFS is close to 1 year finally. And the addition of inavolisib add 1 or 2 months in terms of PFS, with some toxicity, because finally there is hyperglycemia, cutaneous rash, diarrhea. So it will be up to clinical decision in which patient to combine 3 agents or 2. Many trials now are designed to add. We add everything, something new, but we don't take care sometimes on the cost and the safety profile of these combinations. But you are perfectly right.
I have a question that the INAVA 20 study, you have the inavolisib actually piggybacking on palbociclib, which we agree today is, an inferior CDK4/6 inhibitor. So if it were to be combined with the other two, would it really show the same benefit? That is...
No, potentially maybe more benefit because Ribo and Abema are more active, but there is a problem of safety. I don't know how to combine Ribo or Abema with inavolisib because there can be a safety profile. So personally, I believe the best CDK to be combined is for the safety profile is exactly palbociclib. That's why in all studies, combination partner is still palbo. And just a comment, maybe you would agree with me. All these studies have been presented by doctors that graduated in India and then moved in the United States, because here we are discussing about data and trials conducted by Indian investigators. Aditya Bardia, Kumar Javeri, they graduated all in India. So this should be something to be also mentioned.
Yeah, thank you for that comment, Professor.
No, because I know that these people, I know personally, all of them, they did a lot of sacrifice, and finally they have been recognized as global opinion leader. So it's something that we should say.
So just for the last question, and we know that the AKT pathway can be activated also in triple negative. So are there studies looking at the other subtypes where I think it would be a useful addition, especially in triple negative breast cancer?
Yes, the two trials, one trial was paclitaxel alpelisib, the other one paclitaxel capivasertib, but unfortunately both trials failed to demonstrate a benefit also in the subgroup analysis. So even if you are right, the PI3 kinase pathway and the AKT is a relevant pathway in triple negative, I don't believe there will be further development in this setting. The trial presented the negative data.
Thank you, Professor. And now we would move on to a case-based discussion. And I ask my colleague, Dr. Amit Rautan, to take over and, discuss the cases. And the cases are going to be presented by different Dr. Samir Shrigangawar, who is from the NCI Nagpur. So, Dr. Amit Rautan, over to you.
Thank you, madam. Good evening, everyone. So we had a wonderful discussion with all the talks, and we had an excellent presentation and a discussion about all the aspects about all these new clinical trials. And the ER positive space is changing very dramatically, especially the ER second line therapy is changing very, very dramatically. Every day there's new data, and we have to keep learning how to adapt to this data. So I think we'll start off with an interesting case presentation. We have Dr. Samir from Nagpur. Over to you, Dr. Samir.
Am I audible, sir?
Yes, you are.
So thank you all of you for inviting me for presenting this case. So I'll be presenting a interesting case of HER2 low positive metastatic breast cancer.
Sir, put it on a slideshow mode. Play.
Yeah, just a minute.
Yes.
It's okay. So
Yes.
my patient presented initially in June 2021 when she was 38-year-old lady, and she presented with a breast lump in the left breast. It was in the second trimester of her pregnancy, but it was missed by a treating gynecologist, considering it to be a pregnancy-related changes in the breast, and that's why no further investigation was done. There were no relevant family history. Over a period of time, it grew in larger size, and after delivery, because it was persistent, FNSC was done and it was inconclusive. But because of high clinical suspicion, the core biopsy was done after the FNSC, and ultimately it revealed infiltrated carcinoma grade 3, and on ISC it was ER, PR, and HER2 all negative. So it was a triple negative case. And as it was triple negative and she was 38, Gemlan BRCA was done, it was negative. So finally, she was actually non-metastatic on metastatic workup, and that's why decision was taken to treat with the neoadjuvant chemotherapy dose dense anthracycline and taxane-based combination 8 cycle, which we routinely use in all our patients. And after NSCT, she underwent surgery with left MRM and ALND, and which revealed there was some residual disease still present. And after that, she received adjuvant radiotherapy, and then capecitabine was given as a maintenance as per the CREATEX, because there was a residual disease after NSCT and surgery. So this capecitabine maintenance actually finished in December 2022. So she did well for around a period of next 11 months till November 23, when she started complaining of headache and nausea. Because of her neurological complaints, MRI brain was done, which showed two metastatic lesion, which confirmed the recurrence, and eventually it was treated with SBRT 5 fractions. At the same time, PET was done, which showed a systemic disease also with multiple lung and the bone mets. She had a recurrent disease, and it was a triple negative case. That time, directly the systemic chemotherapy with docetaxel and carboplatin was started, to which she responded after initial 3 cycles of chemo with a partial response. And because she had response to 3 cycle chemo, she was continued to complete the 6th cycle. But ultimately, within a short span of time in May 24 only, she developed new brain lesions. And again, that was treated with WBRT. Also, after 2 months of this WBRT, she again developed new systemic lesion in the lung, and the chest wall nodule was also there. So she was progressing very rapidly. This all was treated actually at some other place, and all this clinical history and treatment history she presented to us in July 2024. That is last year. So initially, she had a consultation with radiation oncologist at our center, but re-radiation was not possible because she's already received radiation twice, and she was referred to medical oncology unit. So for the systemic therapy options, so she had basically brain mets, lung mets, and bone mets also. And initially, her disease was triple negative. So we decided to do a repeat biopsy because we have some new options here in such cases. So we decided to do a repeat biopsy of lung lesion. And now this time it was ER negative, PR negative, but HER2 was 1+ this time, which at baseline was 0 only. So after a detailed discussion with her husband, we decided to treat her with the TDXD, considering his benefit and the cost. So once she was started on TDXD, after 3 cycles, she tolerated well, and we did a repeat MRI and PET CT, which showed a good response to the therapy. And clinically also, her chest wall nodule started regressing. So this was a brain MRI. The above image is the image above shows the post-treatment scan, and the image below shows the pre-treatment scan. You can see here how the cerebellar region has regressed, and even the parietal lesion has regressed after 3 cycles of TDXD. Even the PET scan has shown the response in the lung lesions. In the both right and the left lung, there was a response to the TDXD after 3 cycles. So she had a response to the TDXD, and the patient is still continuing on TDXD post 6 months of therapy, and she is symptomatically also much better. So this is a very interesting which shows how the repeating the biopsy and sometimes can change the biomarkers, and how we can open up our newer options of treatment even in very difficult to treat triple negative patients, where we hardly have any options after progression on 1 or 2 lines of systemic therapy. So this was my last slide. I think we can go ahead with the panel discussion on this. Yes. Thank you.
Thank you, Dr. Samir. Very, very challenging case, and always becomes very difficult when you have these triple negatives who progress extensively, and you really don't have too many options, and you keep thinking what to do next. Just a quick question, Samir. Now, are you biopsying most patients whenever they progress? When you have had earlier all triple negatives, when they progress, are you biopsying all of them in the metastatic setting?
We try to biopsy at least once, sir, because HER2 status definitely like 1+ or HER2 low, ultra low. So there is an option of means there is a new term ultra low also. where there is some data which suggests TDXD may work in ultra low also. So we try to biopsy at least once.
Yeah, I think the good information has been these rebiopsies have definitely changed in some patients, and we are able to get them into that 1+ category or 2+ or ultra low. But the good thing is, even if we don't get a new biopsy, what we are doing is we are looking for the old biopsy and asking them to relook at the HER2, rescore it, because ultra low was earlier never scored. So there was no way they would look at it. And so that's the other way we are telling everyone, get a rescoring done.
Right.
I think let's move forward. Shall I say the slides, if it's okay?
Yes, please, sir. Yes, please.
So you can just close this. Yeah, great. Excellent. Okay, so let's quickly have a quick 25-minute panel discussion. Let me invite all our panelists. We have Dr. Sahu, we have Dr. Arun Warrior, Dr. Shruti, Dr. Sachin, Dr. Santosh, and Dr. Andresen. All of us are here, right? Okay. Right. So I think all the question answers have been discussed. Now it just comes down to what individually everyone does in clinical practice. So this is just to kind of take up a case. This is a patient who was T2N0M0, ER positive, PR positive, HER2 0, and this is in a long time back, and she did receive AC for 4 cycles, went on to get a surgery, radiation, adjuvant letrozole. HVOC panel is negative, and she completed 5 years of letrozole by July 2019. Now, presented with severe back pain, and an MRI done shows multiple bone mets, and the PET CT shows multiple lung mets, pleural base mets, and liver mets also. Biopsy again done from the liver shows ER positive, PR positive, HER2 1+. It's written FISH negative. We usually don't do FISH for 1+ patients, but anyway, it must have been done for this patient, and the FISH is negative. And the KI was 67%. Okay, so this is the patient, and so this is, we'll have to see, this is 2022. Okay, Dr. Arun, starting from you, how do you proceed in this patient now?
I think so. She has progressed after 3 years after stopping endocrine therapy, and definitely she doesn't seem to be in a visual crisis at this point. So 2022, I will go for CDK4 inhibitors plus letrozole.
CDK4/6 letrozole straightforward is the option, which kind of is quite a well used option now. I think in many years everyone's kind of straightforward goes to that. Dr. Sahu, if there was visceral crisis in this patient in form of liver maybe, or what visceral crisis would tempt you to go to chemo, or do you go to chemo ever, or do you not?
So there's a visceral crisis, but if the LFTs are not too grossly deranged, and OTPD especially, so I would be very confident after the data we have been seeing across the clinical experience, are also the right trial of letrozole in where 50% or more were from liver crisis, a visceral crisis. So they did show that compared to chemotherapy, AI plus hormone is superior in terms of response, the time to response, and even in the PFS data set. So I think today, till it is a point where I feel that I cannot give a letrozole or AI, there's some specific toxicity inhibiting me from that, I would be more comfortable today in such patients for a CDK4/6 plus hormone therapy. And I think my practice is changing gradually. Yeah, and to add to that, just a quicker, we went to chemotherapy and it was not based on any level 1 evidence. Right. It was just out of guidelines practice.
Right. No, I fully agree with you. It's how it's changed in a few. We started with less symptomatic patients, bone met patients. We kept saying, okay, organ involvement will be worried, but we got more and more confident. And I think these trials add on more and more value, saying even in visceral crisis, you can definitely go in with that high response rate using a CDK4/6 AI. And I think all of us have kind of go in that direction.
Sir, in couple of areas, I still prefer chemotherapy, especially one patient, if the patient is having pleural effusion and on pigtail. In such patients, still we are using chemotherapy. And recently I had an encounter. One patient had an axillary lymphadenopathy, and because of which patient is having neuropathy also. I started with abemaciclib thinking that it might work better for the patient, but the pain is not settled down. Then I need to go back to chemotherapy, and then it got better. So there are some gray areas that there's still chemotherapy holds back.
I really don't think for pleural effusion we could just tap it and just start off. They do respond really well with CDK4/6 AIs. We're just doing that routinely. We just tap them and start off. We don't bother too much about, even if they don't get to a pigtail.
Pleural effusion with symptomatic pleural effusion. If not symptomatic, they are responding well. But in symptomatic effusion requiring pigtail and prolonged admission, that's one area.
No, Arun, your thoughts?
No, I think pleural effusion is eminently manageable because the pulmonologists are nowadays doing, they even do pleural suffering. So they know the survival is going to be good. So like that, we have patients and then we can avoid chemo. That's what I also feel.
Yeah. So everyone has those individual patients where, we say they didn't do really well with CDK4/6, but they are very selected patients. CDK4/6 AI is not select. But I agree with you. Everyone has their own individual nuances to choosing a patient. I've seen situations where the liver mets are starting to cause the LFT to start getting declined, and I don't know what to do. I don't know whether should I go this direction or this direction. Little bit of bilirubin starting to rise, and it worries me a lot. Those are situations where I really get worried. But I think everyone develops nuances to it. Let me ask Kruti, which CDK4/6, a difficult question these days, which CDK4/6 with AI for this patient, postmenopausal?
I would prefer ribociclib for the patient and or riboabemaciclib. If cost is an issue, then Palbase is the choice which most can afford. So that is how I choose for the patients. Especially if LFT is involved, then giving ribo gets a little tougher than abemaciclib. And if cost becomes an issue, then because we have generates of palbociclib, then I would offer palbociclib to the patient with a hormonal which they have not received before.
I think so definitely ribociclib, and this the AI data is so strong with the OS data that it's become dominant.
I have a point here. I may be wrong. I understand why all are saying ribociclib because of the OS data and other things. So, but if I look at it and I look at the primary thing, what we look at a drug efficacy is the PFS. And if we look at the PFS, all the three CDK4/6 are same, at least in the metastatic setting. This is where we are discussing. So I have still a reservation about my choice of a drug, just because, and all of us will agree that ribo is much more difficult to manage than a palbociclib. Right. And the PFS data is not there. Right. And I strongly believe that this thinking, just because of the OS data set, I don't know. I have my reservations with that.
That's how I said, coming to the difficult question. I think this is the most difficult question. If someone says, do you really believe one of these is really superior than the other? It's impossible to answer that. I think
the data does not support that.
Yeah, exactly. The PFS is exactly the same. Everyone's clinical experience has already been developed. So that's a very difficult choice to make. Though now, because of the OS data, ribo is becoming a dominant one being used, and it's changing the whole landscape in the West also. But till now, it was always palbo. That's the way it is. And unfortunately for Abema, just because they missed the number, but actually the magnitude of benefit.
Yeah, the hazards is nearly the same as it is for ribo. It's a very few patients.
I still find it difficult in practice when you want to choose the three, when the patient tells I can afford everything, what do you say we should choose? And I still have a little difficulty because the PFSs are exactly there. But again, the OS kind of makes you, at least you can talk about the OS there. In the rest of them, you can't talk about the OS data as of because they are negative studies. But clearly, it's a difficult choice.
And does the endocrine refractoriness matter in choosing this frontline AIs? Sorry, CDKs.
So if you're saying they relapse after adjuvant within a year?
So let's say adjuvant and they relapse within 12 months or maybe 24 months, the primary refractory.
Yeah. So again, that's where the palbo data actually comes out that way, that the benefit was lesser, especially.
So ribo versus abema is what I wanted. What would you think?
Again, both the data sets are, so if you again go by the PFS, it's exactly great in both. It's really not, though one talks of the one way and the other talks the other way, saying that we had more refractory patients, but eventually if you look at the PFSs, they're exactly the same. So it's a very difficult question to answer in the present era. And it's challenging, It's okay. I think we'll be that's
Sir, Samir here.
Yeah, Samir, you're
Definitely there is something different in all the three drugs because although the PFS is similar, toxicities are different.
Yeah.
Efficacy at different sites, like some are more active in brain. Like even the data in adjuvant setting is negative for one, positive for one. So there is something which is different in all the three drugs. That might make them the different drugs.
What you're saying is perfectly correct. It's just that dilemma will never end, because the PFSs were exactly the same. That was the primary endpoint. But now the OS data is matured in such a way that Ribo is becoming a dominant drug when everyone says OS is the gold standard. So I fully agree, and I don't think this dilemma will ever end. I think Shruti put it wisely, saying that patients who can afford and not afford, that becomes much more easier in practice. I think all our own personal experiences add on a lot when we choose drugs. Okay, we'll move forward. Otherwise, we'll not get into this because this debate never ends. Anwar Sen, you said about the resistance. So, do you do NGS testing in this setting when you got a patient with metastasis? Do you look for some things in this setting, or you say CDK4/6 AI is clearly okay and I don't need any testing?
Sir, at this point of time, we are doing with CDK4/6 inhibitor with endocrine therapy, not with NGS testing. That's the practice.
So no testing at all.
At least in first line, no testing.
Right. At least first line, no testing. Sachin, with that Innova data coming in now, with PIK3 becoming one of those kind of mutations for that population, do you want to look for it and keep that information ready? Okay, we don't. Sachin is not there. Okay, Santosh?
Sir, in one particular subset, maybe we may have to do upfront, sir. In those with primary endocrine resistance, those who progress within 12 months, these are the subset where I would do a liquid biopsy, because in this subset where there is rapid progression, Innova has showed advantage. PIK3CA positive with early rapid advanced progression, that is primary progression. In this subset, yes, I would do. Or else, if they do not fall into this criteria, I would straight away give CDK4/6 plus AI. If progression, yes, primary progression, yes, we have to do.
Right. So I think as Santosh mentioned, now it's going to become important for us that primary progressions, we need to know the PIK3 status. So that's one test we may need to do.
Sir, sorry to interrupt you, but your slide is not moving.
NGS testing really has any benefit in this line, though some people do it at this time and some people say we will do it next, which is perfectly fine. Right. So this patient gets a rebiopsy and gets this mutation, gets this answer of ERPR positive HER2 1+, and is started on palbociclib and anastrozole. I think we discussed this, and we discussed this also, that PFSs are bang on, and we have also discussed that the OS data. No chemotherapy we have discussed. Now patients did well and now develops progressive disease in liver after 10 months. Okay, so this is now the progression. Arun, your thoughts on this now?
I think for somebody progressing on CDK4, I think this is possible. So now with the PIK3 positivity, we have there's something to give to her. So we can start her on the therapy.
Right. And at this time, are you really testing for anything else apart from PIK3, or are you sending NGS? What do you do?
See, it again depends on the patient preferences. We don't have much to do because it seems to be an aggressive disease at this point of time. NGS picking up other things, the possibilities are very less. But if we want to rule out everything, and if they are the patients are asking for that, I may do it. But that there are not much. We may not get much to offer to them on NGS.
Right. No, I think we do test a lot, but eventually the information is very limited. We only see PIK3 mutation, we see ESR1. Sometimes we pick up a somatic BRCA, but again, that would have actually been picked up from the hereditary panel also if required. It's only rare patients have that somatic alone. But probably, and some patients we have seen with HER2 mutation, these are the only things which we have picked up when we have done a lot of NGSs at progression of CDK4/6 and AIs. We have really not picked up something dramatic. But anyway, this patient is PIK3 positive. So
Sir, at this point of time, we can test for genetic testing also. Like we have data for BRCA1, BRCA2, and PALB2. That also be an option for the patients.
yes, so the HPOC panel is something that this was already done in negative, but that's something that should always be there for patients whenever you're doing that. That test should always be there. Right. Great. So now this patient today and everything available, what are the thoughts you have among these options, and how do you think about it? Shruti, what are your thoughts? You have a PIK3 mutation positive patient.
I'll go either for A and B. So alpelisib with fulvestrant, or I actually don't have an experience with the capacitinib, but I would love to offer it to the patient if given the chance. So I think so. First two would be I have used alpelisib a lot, and I've seen it when patients progress early with CDK4 inhibitors, this with PIK3 mutation coming up, they really do very well for at least 3 years, 2 years follow-ups. Is that what we have with it? So
yeah, so when it works, it actually works very well. Unfortunately, toxicity is the major concern, but otherwise, when it works, alpelisib fulvestrant has been a really good option for our patients. Sahu, any time fulvestrant everolimus versus fulvestrant alpelisib?
I think both are dirty drugs. You have this everolimus, which is as dirty as alpelisib. Alpelisib might be a more dirtier. That's the only point. So we have, but my point is, if everything is available, I'm really impressed with the Innovo 120 data, and I would like to get a hand on it. The PFS is excellent. You have seen a doubling or more than doubling of a PFS, which you have not seen anywhere. So I think this it will and is bound to change the treatment as it comes into within few months. The inavolisib drug is going to be a great option for this. Capivasertib looks little better than alpelisib. I think on the toxicity profile, although the hyperglycemia and other things do stay on. So that is the problem with the PIK3 is that the toxicities are bad for most of the agents what we have. So I'll go for it 1 and 2. If cost is the issue, then 3 definitely comes into because the generics are available. But the Innova 120 data is something that is bound to change the way we look at this field actually.
Agreed. Innova actually is really remarkable. But only thing, Innova is only for that within 1 year progression from adjuvant.
Yeah, so this is typically your patient actually 10 months. So that's what it is.
Right. But definitely the way it's being thought about is definitely targeting PIK3 will forward. Right. A quick thought on re-challenge with CDK4/6 inhibitors. Santosh, how has it been with you in practice? What do you think about these data sets and practice? Both data sets and what is in your experience?
Sir, in my experience, if there is oligo progression, sir, only few sites progression, in that scenario, that really gives us confidence to continue CDK4/6 and just change the hormonal pattern to fulvestrant. That is one I do. In data sets, what conclusively they have told is, if the patient is on palbociclib, changing to Abima or ribociclib might add few additional PFS. Continuing palbo with palbo might not give us more benefit. So if the patient started on palbo, then changing to Abima might add maybe 4 to 5 months of PFS. But my practice, very mild progression, I tend to continue the same with change of hormonal partner.
Right. I think what you have said is perfectly correct. Getting oligoprogression patients are the only ones who really are the ones whom we are continuing and they're doing well. I think initially we did try continuing even for others and just saying change the hormonal. We didn't see anything great, at least. At least that's been our experience.
Agree, sir. Agree.
We have not been great fans of re-challenging. Though I would say the way the data is changing and the way the EMBER-3 is making us think again about all adding re-challenge to ESR1 is again changing our thoughts, but it's amazing to see how it is. Dr. Anderson, if you had a ESR1 mutation and you didn't have a PIK3 mutation, what do you do in that situation?
Sir, with respect to ESR1 mutation, the more the patient on CDK4/6 inhibitor, the better the result with the ESR1 mutation. So if it is beyond 1 year or 18 months of CDK4/6 inhibitor, then the elacestrant will benefit much more in the population. And also we need to keep into account that majority of the patient progress within the early part. In the less than 3 months, almost 30% of patients have a similar event compared to the placebo. That part also we need to take into account. And with the upcoming data coming more with respect to Destiny trial, TDXT also coming into picture. So if the patient is having really highly aggressive disease, I would like to think in terms of TDXT also in this scenario.
Right. So definitely trying to think of post that also, and TDXT definitely will have a role also in this place kind of patient. It's very complicated and a very crowded space now. But what was very interesting is they were talking of the type of ESR1 mutation and so they don't stop at ESR1 mutation. They say you read the numbers after that, and that becomes so difficult for us. And they say these subtypes matter about how you'll get responses to various ESR1 inhibiting drugs, and that's amazing to see where the space is going in. But fully agreed. If patients who do very well on a CDK4/6 and then progress, they are the ones who are responding best to elacestrant. At least for now, that's the only drug available. And I think with more drugs coming in, that space will again change. So I think all these spaces about this CDK4/6 inhibitor after CDK4/6 is for that selected population only. The oral SERDs, I think we have only elacestrant, but the data sets are really very good. Especially, I think EMBER-3 data is really very, very eye-popping. The way the numbers you have hit in and the numbers of PF gotten in EMBER-3 by the combination of imlunestrant plus abemaciclib. And I think Serena has very nice data. I think the new Serena trials are even more interesting, where they have actually built in the first line setting with doing a ctDNA and then taking a ctDNA and then deciding to change. So just like the PADA-1 approach, which was done, which was very nice. The PADA-1 trial was very ahead of its time, looking at Palbo AI. And then when you got a ctDNA showing a ESR1 changing into fulvestrant Palbo, and that was really very nice. And that's good to see now phase 3 trials taking ctDNA forward. And I think the Serena 6 is, I think, doing that, and that's also very, very interesting. So I think these new trials which incorporate ctDNA into it will be really very kind of educative for all of us and our patients. Okay, we did discuss about Capitello, and SOLAR-1 is right there, and that's the way forward. Okay. So I think we did discuss this, and we are very happy with testing, and we all want to test, and that's where it is. Okay. Shruti, you spoke about alpelisib, and you've had patients who've done well for long term. What dose have you got set into? How do you take your patients through the toxicity? And moving forward from that, what do you think of the Capitello data set for the toxicity point of view? Okay, I think Dr. Arun is there. I lost Dr. Arun at that time. Arun? Hello? Am I audible or not there?
You're audible, sir.
Okay, I think okay. Who's in there? Santosh, you're there?
So the question was on. Hello, Dr. Arun might answer that. Hello.
Yeah. Yeah, I'm not getting Arun in, I think. Okay, Dr. Santosh, you take it.
Yes. So the question was on capivasertib versus alpelisib. That was the question, right?
Yes.
So as we see the toxicity profile, the tolerance ultimately matters. In alpelisib, the issue is that rash, hyperglycemia. And the capivasertib, the additional is AKT P10 also it covers. It covers the comprehensive pathway, whereas the alpelisib, it covers the only PI3CK. So more robust, less toxic is capivasertib. If that is available, that would be my choice compared to alpelisib.
Okay, yeah. So the toxicity has been much lesser, and I think the best thing about Capitello was where they were very lenient on taking patients, and I think the HbA1c cutoff was very high, somewhere around 8, which was about 6 in the SOLAR trials and all that, where it had to be very low, and still their hypoglycemia rates were not very high.
And not requiring insulin, I think.
Yes,
the
yes.
inclusion was not required. Yes.
Amazing. It was amazing. Anderson, do you think that this difference, is it the drug or is it the schedule? Daily versus 4-3?
So actually, I listened to the lecture by the author himself. She specified that the schedule made the much difference. 4 days on and 3 days off made much difference. And also they started prophylactic antihistaminic for those patients and they counseled very well. That schedule has made much difference in terms of population. And they used this combination in elderly population also with a similar dosage and they tend to do much better. That's their opinions.
Right. So I think it's both. The schedule was very important. The counseling, the learning curve was very good.
I think it is a matter of also, Amit, the way people have learned from alpelisib. Because if you learn from your old trials, and that is how you modulate it, and that's why the newer trials will have more tolerability because these drugs were pretty new when this trial of SOLAR was done, and now people have learned and burnt fingers enough to know, and that is how it progresses actually.
Absolutely.
Agreed. Capitello toxic data is much better than SOLAR.
Absolutely. You're perfectly correct. A lot of experience and everyone has got their hands on it now. And everyone knows now they're not worried about the sugar part. Okay, so now we have finished this and alpelisib and Capitello data we have seen how all the data sets there, and clearly we believe blocking the PIK3 pathway is very important, fruitful and helpful, but toxicity needs to be managed, and all of us have discussed how the toxicities have been different, but definitely capivasertib has been much better tolerated drug than alpelisib and everolimus. Okay, so this patient again progresses, and this patient gets on to capecitabine. I think in the present era, again that's that time when they got into capecitabine, but HER2 1+. Where are you thinking in terms of using TDXT? How early are you ready to push it in? Arun, your thoughts? If you're there.
You're muted, Arun.
Yeah, sorry. I think with the TDXT coming up, it's better to use it little early on, because once the general health goes down, and now we have data also to use it little more early in the disease process.
So when do you do it? You would do it 2 lines of hormonal, 3 lines. How do you think about it?
Again, I think it's based on how much the response was on the hormone therapy. So maybe after the first line of hormone therapy, we can think of it.
I think I will, for such a patient, I'll at least finish 2 lines of hormone therapy because that is the primary driver. So this is my thought. And sometimes you can even go for 3 lines of case basis. But yes, before capecitabine, if patient can afford it, I think the TDX should be in. And we had the 1+ case shown by Samir, and it was a terrific response. So I think people should be using at least post 2 lines or 3 lines till something has there's a trigger not to use those hormones before. And the entry criteria was also similar, I think.
Absolutely, you're fully correct. So as Sahu is saying, finish all your hormone therapies first. For DB04, we actually had to finish all the hormonals and 1 line of chemo and then take them up for TDXT. Yeah. And DB06 changed that, and at least we said finish all your hormonals and then go directly to TDXT. You can avoid that 1 line of chemotherapy. So you moved it 1 step forward. But I don't think I know. So we keep showing those PFSs, and it keeps getting shown that if the PFS in the second line hormonal is only 4 or 5 months in the CDK4/6 era, even with the best of things, and we don't have any of the new drugs, and here you hit a PFS of 12, 13 months, should it be moved upfront to one line of hormonal? But I think clearly we should not at present, we should not be doing that. We should finish up our hormonal regimes, and then once we finish the hormonal, going to TDXT is probably the way forward. A quick question about so we finished this and ultra low. I think this is interesting space. Are you Sahu? Are you confident enough? You get an
I am not confident enough of the reporting of the ultra low. And if you can see the discrepancy of the ultra low reports that's there in the data set also between the central and local, that is something we need to know, that the data is good. The data is not bad in this scenario what we have. But are we missing? Are the pathologists not able to pick up those ultra lows? That's a confusion between the IHC 0, the ultra low, and the 1+. These three are going to tricky. And if you look at the endometrium data also of HER2, the Destiny Pan, you see a lot of discrepancy in these 0 and 1 with the IHC reporting from central and local. So I think that we have to train the pathologist first. Then only it comes into. And second, the CAP has, if I'm not wrong, has not even recognized this entity at all till now. So that is going to be difficult. So yes, the data is not as great as we saw in Destiny 06. Sorry, the 1+ and others. The ultra low still looks impressive.
But Arun, you would think we saw the DESI data with even some response in 0. So we say if they're ultra low, even if they're 0, at least they respond somewhere. It's okay. What do you think?
The problem is that to get the pathologist, they're still not committing because the CAP has not recognized, because all the means whatever the accreditation they have, they are very hesitant to report that.
Yeah,
it's not easy.
So, correct. So I think we have to talk to all our pathologists. So now our pathologists are kind of reporting as per CAP, and then they're putting that addendum note down, and then they are saying this could possibly be an ultra low. This would be into the ultra low segment if we did it by this kind of.
My point, Amit, was even if the reporting and the discrimination is still too high, they need to be trained, and that training, I don't know how long will be that period when they can confidently report, because there is at least 1 to 2% becomes 10%. There's a gross difference, and the dichotomy is very much visible even in these trials.
No, absolutely. It's something. It's like that learning curve for the pathologist also.
Yeah.
That's the so. But again, the data, if it is ultra low, also is very, very kind of impressive. At least it opens up one opportunity if it is there. But again, as Sahu said, one has to really be sure that we are dealing with that, and that's the way forward. So I think algorithms have changed, and clearly, I feel hormone receptor positive at progression is becoming very challenging. You sit and discuss so many options, and you're not sure in your own mind. And when you're not sure in your mind, you confuse patients even more. And that's becoming an issue now. You really don't know, should you hit the PIK3 pathway? Should you not hit the PIK pathway? Should you re-challenge? And this is only when we don't have so many drugs with us. I think it's an amazing space. We have
You can bring in the DATO data. So bring in and you will confuse more.
There's no doubt about it. More and more ADCs into that space. But again, it's so much more to do for patients. I think that's okay. But for us, it's becoming a lot of learning. And but we have good times ahead. I think this is the last slide. With this, I thank all the panelists, and I thank everyone for being here in this meeting. It was as we said, the learning experience. We are all learning how to utilize these new drugs, how to use it in the correct space, how to put it and manage toxicities. And I think personal experience will be very important. It's just like the CDK4/6, how we got our own personal experience. All of us became comfortable with some regime, choosing the right patients. And I think that's exactly what we are going to be doing, even in the second line setting, third line setting. And with this, I thank everyone, and thank you very much. Over to you, AstraZeneca.
Now they are missing. We can log out.
Even